So welcome back. I'm Alistair Hill. I'm lead for the NHS Standard Contract at NHS England. And as I say, welcome back to the second part of our presentation about the new standard contracts for 2017 to 19. As I described before, the presentation's in three chunks. And in this second chunk, we want to go through some of the new policy requirements that we've included in the contract for the next 2 years. I'll start by going through some of the changes that are particularly around the interface between secondary care and primary care. Then I'll hand back over to Michelle, who'll take you through some of the other main policy changes that we've included in the contract as new requirements for next year. And finally, I'll say a little bit about service development and improvement plans. The contract says quite a lot now about the interface between primary care and secondary care. And why is this so important? This has been something we've been pushing in the contract in both 16-17 and now for 17-19. Why is it so important? Well, it won't surprise anybody if I say that GP practices are under a very considerable workload pressure. And NHS England is committed to helping to try to minimise the administrative burden on practices so that clinician time and administrator time can be freed up to best clinical effect. And sadly, one of the key sources of avoidable extra work for practices is when secondary care providers organise things in a less than good way. So if they don't organise patient care efficiently, or if they don't communicate well with patients or practices, that's when extra workload for practices can build up. And that's why we're taking action through the standard contract to try to bring hospitals particularly towards a better position in some of these areas so that the way they're operating is both better for patients and doesn't cause this extra workload, avoidable workload for general practice. And that's also why in July of this year, a letter went from the top of NHS England and NHS Improvement to chief executives of trusts and CCG accountable officers, stressing the importance of fully implementing the new requirements around this area that we'd included in the contract for this year, 16-17. So this is really important territory in terms of NHS England policy requirements. I would say, though, that nobody is putting all of their eggs into the NHS Standard Contract basket in this respect. Everybody recognises that the contract can help with some of this stuff, but it's not the only answer. So there is a working group made up of eminent people from national clinical organisations, the national medical bodies and colleges, which has been set up with NHS England and NHS Improvement involved to drive further action, not just through the contract, to try to improve the interface between primary care and secondary care. So then coming back to the detail of what's in the contract, there are a number of requirements which are unchanged from 2016-17, and it's worth going through those quickly. The first of these is about local access policies. Local access policies generally set out how a hospital will deal with situations where a patient has an appointment but cancels or DNAs. And what the contract wording is making clear is that the provider must publish a local access policy, which has always been the case under guidance, but that policy must not have a blanket approach whereby any patient who DNAs for a clinic attendance is automatically discharged back to their GP. The situation has to be that that's a clinical decision made in the light of the individual patient's circumstances, so that the idea is we're not just seeing patients discharged back to general practice land who will automatically be re-referred, just creating an extra appointment in general practice to no real purpose. So that's local access policies. Then there are arrangements in the contract about onward referral. Now these have been in place for some time, particularly as a control, I suppose, on the ability of the secondary care provider to refer patients on for extra treatment in an uncontrolled way that could potentially just generate more income for them. So the contract has always prevented providers from referring on patients for unrelated, non-urgent conditions, so conditions that aren't related to the reason for the original referral. In that situation, you have to refer back to the GP, because the GP may decide that that can be dealt with a different way, can be dealt with locally in the practice, or doesn't need referral. So that's still the case. What we changed in the contract for 16-17 was to emphasise the reverse, I suppose, that where you have a referral that is related to the reason for the original referral, so you're trying to refer someone on to the next step in a logical care pathway, in that situation there's no need to refer back to the GP. The hospital can simply make that referral. There's no need to put an extra step in the process and make the patient go back to see their GP again in order to get that onward referral. The third area on this slide is a relatively simple one about GP feedback, making sure that hospitals take account of GP feedback and involve GPs when they're thinking about how they design their services. Again, a fairly straightforward and unsurprising inclusion. Finally, on this slide, we included some new requirements for the 16-17 contract about medication that's given to patients when they're discharged from inpatient or day case care in hospital. And we worded this very carefully to say that the medication to be supplied must be for whatever period is set out in local protocols or established in local practice, but it must at least be for a minimum of 7 days. So it was setting a minimum standard, not preventing you from having an agreement which was for a longer period than that. So then moving on to things we've added or changed for 17-19 then. The first of these relates to fit notes, which if you're slightly less than au fait with the terminology, you might still think of, as I do, as sick notes. Anyway, hospitals are required to offer fit notes to patients where they need them, and that's been the case under Department of Work and Pensions guidance for many years. We've simply reflected that guidance more clearly into the contract now. But it's worth pointing out what we're trying to achieve here. Basically, what we're trying to avoid is a situation where the hospital doesn't bother doing a fit note for a patient when it could, and instead the patient then has to traipse back to the GP surgery as an extra visit to get that fit note there and then. But we're not saying that hospitals should call patients in for extra appointments simply for the purpose of getting fit notes. This is about offering fit notes in the course of normal care and treatment that you would be doing for the patient as part of the patient's care pathway. So then, moving on to discharge summaries, the next area on the slide. Now, a lot of this was in the contract prior to 16-17, but the basic requirement is that providers must issue discharge summaries for every patient discharged from inpatient or day case care within 24 hours of discharge, and they must do so electronically to the practice and using a structured message format with standardised clinical headings. What changes for 17-19 is that this requirement is extended to cover discharges from A&E, and that comes in from October 2018, and also that the whole set of requirements for transmission of discharge summaries and clinic letters, which we'll come on to, that moves from being an option between doing that by email or by direct electronic transmission. From October 2018, it becomes direct electronic transmission only. So those are important changes for discharge summaries from acute hospital care. But it's worth saying as well that if, as Commissioner, you want to specify discharge communication requirements from other services, community services say, we don't mandate that through the contract's national wording, but you can set that out locally in Schedule 2J, the schedule with transfer and discharge protocols. We then come on to clinic letters, where again there was provision within the 16-17 contract which we have tightened for 17-19. An important difference here between clinic letters and discharge summaries. So a discharge summary has to be provided for every patient. We're not saying that that's the case with a clinic letter. There are situations where a clinic letter won't be needed. But where there is information which the GP needs to access quickly in order to manage the patient's ongoing care, that's the situation where the provider must provide a clinic letter to the GP. Now, in the 16-17 contract, the timescale for that is within 14 days of the attendance, and that's what's reducing in the 17-19 contract. So the requirement from April 17 is for that to be done within 10 days, and then from April 18 it falls to 7 days. And as I said before, the requirement moves to being one to transmit by direct electronic transmission from October 2018 using, again, structured message format and standardised headings. And the point about the delayed timescale for some of this is that for clinic letters and A&E discharges, the standardised clinical structure still needs to be finally developed and published. So that's why there's a gap, if you like, in the implementation timescale for those requirements. So the next point is about medication following clinic attendance, and we've added new provisions here which are about requiring the hospital provider to supply medication to the patient following clinic attendance if the patient has immediate needs. Now again, we've said that that should be for the period set out in any local protocol or established in local practice, but it must at least be sufficient to cover the patient to the point at which the clinic letter is going to reach the GP. Because what we're trying to prevent is situations where the patient runs out of medicine that the hospital's prescribed after 4 days, goes along to their GP surgery asking for a new prescription, and the GP hasn't yet got the clinical advice from the hospital consultant saying what needs to be prescribed. That's going to be a wasted appointment in primary care that they can well do without. Finally, on this slide then, a different requirement, this time on the commissioner side of the equation, a new requirement around commissioners trying to make sure that GPs supply proper, accurate referral information with every referral, patient contact details, other clinical and administrative information that's needed. Finally, on this section, 2 more points about how care is organised and communicated to GPs and patients, and how queries are dealt with. So the contract sets out a clear requirement on the provider to organise the different steps in a care pathway in a logical and efficient manner, and to communicate this clearly to patients. And it's particularly important that test results and the results of treatments and investigations are notified by the hospital to the patient direct, rather than expecting the practice, the general practice, to be the middleman for that process. And then similarly on patient and GP queries, we've strengthened the contract wording in this area quite a bit for 1719, making clear that we're expecting hospitals to have efficient arrangements in each service for dealing with queries from patients and from GPs, and for publicising those arrangements so everybody knows who to contact about what. And particularly that in dealing with queries from patients, hospitals deal with them themselves, rather than referring something that the hospital knows the answer to and should be dealing with, referring it to the general practice and saying, go ask your practice about this, because the practice probably won't know the answer. So please follow those points in how you organise communications with patients and handling of queries. So I'm now going to hand over to Michelle, who's going to take you through some of the other new policy requirements in the contract for 1719.
Okay, thanks, Alistair. So this section of our presentation deals with the other new policy requirements which we've included in the 1719 contract. The areas I'm going to talk through are all the things that have been included in the full-length contract. Where relevant, they've also been included in the shorter form, but in many cases we've not felt that that was necessary. One of the most important areas of these new policy requirements refers to the use of the e-referral system. So, the NHS e-referral system. Ever since the introduction of Choose and Book and its successor, ERS, the key goal in policy terms has been to maximise the number of GP referrals made on the electronic system rather than on paper. So this isn't just about the benefits of going digital, it's also because the use of VRS is much more likely to prompt GPs to have proper discussions with patients and about their choice of preferred provider. And choice remains another key national policy. So, uptake of VRS is being incentivised by 2 complementary national policies over 1718 and 1819. Firstly, for 1718, there's a national CQUIN indicator, and this will incentivise providers to maximise ERS slot availability during 17-19. The goal behind this is to get as close as possible to 100% uptake of ERS for GP referrals by March 2018. From October 2018, the contract then introduces new requirements on ERS at Service Condition 6. Our original proposal in the draft contract was that providers would no longer be paid for activity resulting from referrals made by GPs other than through ERS, but that equally providers would be able to return such referrals to GPs. This proposal generated a lot of feedback during consultation, and we've made some changes as a result. The key changes are to clarify 2 points. Firstly, that non-payment relates to the first outpatient attendance following any non-ERS GP referral. And secondly, that guidance will be issued on referral return and non-payment, with the contract wording explicit that the provisions will operate in the context of this further guidance. So this means that we'll be able, over the coming months, to clarify the policy aspects on which there were most feedback. These were whether there should be specific exemptions to the referral, return and non-payment approach, how the return of referrals to be managed to ensure patient safety, and whether there should be specific services or scenarios where use of ERS for all GP referrals would not be mandated. The next area to cover is around standards for 7-day services in hospitals. The 7-day services standards were announced some years ago, but we've always recognised that most hospitals are not in a position to achieve them all. So for several years, this has been an area where we've required a Service Development and Improvement Plan, an SDIP, to be agreed locally, setting out what would be done within the available resources to move towards compliance. For 17-19, we're moving away from the SDIP approach. Instead, for the first time, compliance with the 4 key priority standards is becoming a contract requirement at Service Condition 3. However, this is only for providers of the specific services listed on the screen. It is only in relation to those specific services, and it is only from the 1st of November 2017. But all hospitals are required to complete the National 7-Day Services Self-Assessment and to share a copy of this with their Commissioner. Another really important area is around discharge from care. We've strengthened the requirements here in a number of ways, all set out in Service Condition 11 and in the associated definitions. The most important change is in Service Condition 11.2. This already set out a best efforts requirement on the provider to do everything it can to avoid circumstances which are likely to lead to emergency readmissions. We've amended this in 2 ways for the 17-19 contract. First, we've turned it into a requirement on the provider and on each commissioner. And second, we've made it about supporting safe, prompt discharge from hospital as well as avoiding readmission. Best efforts is a strong statement, so the contract does now give providers an explicit lever which they can use if they believe that inaction by commissioners is causing delayed discharge and knock-on effects in hospital services. Otherwise, on discharge, it's worth noting that we have significantly updated the definition of the transfer and discharge guidance and standards, which the provider must comply with. This now refers to 2 recent NICE guidelines, NG 27 and NG 53, dealing with the transition between acute or mental health inpatient care and community or care home settings. The transfer and discharge guidance and standards also refers to statutory guidance published in respect of the Care Act and to the new information standard SCCI 2075 around the use of assessment, discharge and withdrawal notices between hospitals and social services. Also, the transfer of and discharge from care protocol, which is agreed locally and included at Schedule 2J to the contract, must now include content based on the National Template Policy, which is supporting patients' choices to avoid long hospital stays. Links to all of these guidance documents can be found in the relevant definitions at the back of the general conditions. I'm now going to talk about a number of other new but relatively small scale requirements in the 1719 contract. The first of these are around self-care and coordinated care. We've included new requirements in these two areas at service conditions 8 and 12 respectively. They're both quite high level, but we think they set a reasonable expectation for what a good provider should be doing. On self-care, the requirement is around supporting patients to develop the knowledge, the skills and confidence they need to take increasing responsibility for managing their own ongoing care. And on coordinated care, the aim is to ensure that a provider's staff work effectively and efficiently together across professional boundaries so that patients experience coordinated high-quality care without any unnecessary duplication of process. The next change is on education, health and care needs assessments. These are joint assessments for children and young people with special educational needs and disabilities, which providers of clinical services are often asked to input into. Existing legislation requires providers to respond to such requests for input within 6 weeks, but the evidence is that this standard is often not being met locally. To remind providers of the importance of complying, we've included this as a new contractual requirement as Service Condition 10. The next change is about the Workforce Disability Equality Standard, or WDES. This is another case of the contract referring to a new requirement which will come into force in the future rather than on the 1st of April 2017. The contract already includes a requirement for providers for implementation of the National Workforce Race Equality Standard. As recommended by the Equality and Diversity Council, a new National Workforce Equality Standard for disability is now being developed. So the contract includes a requirement on providers to comply with this from April 2018. The next change to highlight relates to managing conflicts of interest. As people know, NHS England has just completed a consultation on new system-wide guidance on the management of conflicts of interest and of gifts and hospitality. The final guidance is expected to be published shortly, and the contract requires compliance with this at General Condition 27. The final change in this section is a wider public health provision relating to food and drink sold on NHS premises. The contract already requires the provider to have regard to, and when mandatory comply with, what we term food standards guidance. This includes the government buying standards, which set out a range of mandatory and best practice requirements in relation to healthy eating and drinking options and environmental factors. We've extended this for 1719. When a provider is negotiating contractual arrangements under which a tenant or equivalent will sell food and drink from the provider's premises, then the provider must firstly ensure that the contractual arrangements require the tenant to provide and to promote healthy eating and drinking options, including outside normal working hours where relevant, and secondly, to adopt the full range of mandatory requirements in the government buying standards. And note that this applies to the mandatory requirements only and not the best practice ones. The next group of new provisions I want to come on to relate to the various aspects of data and information technology. So firstly, data security and information governance. The Department of Health is expected to publish the final standards shortly, along with guidance on implementation, and the contract requires providers to be able to demonstrate compliance with the new standards over time in line with the detailed requirements to be set out in that guidance. So this is another example where, within the context of the 2-year contract, we're having to refer forward slightly towards new standards and guidance, which will apply, but which haven't yet been published in their final form. The wording on this is on General Condition 21. Similarly, the recommendation in the National Data Standards is that the current Information Governance Toolkit should be replaced in time by a new Data Security Toolkit. There is some wording on this in General Condition 21, which now refers to providers demonstrating satisfactory compliance with the IG Toolkit or any successor framework. Just to be clear on this, the wording satisfactory compliance is carefully chosen because this is how the current IG Toolkit describes Level 2 compliance. So the requirement in the contract remains for providers to be able to demonstrate Level 2 compliance with the current toolkit until such time as it is replaced. Moving on, we've included a new requirement in Service Condition 23 on data sharing agreements in relation to urgent and emergency care services. Detailed guidance on this requirement has now been published. It's available via the 1718 contract webpage. The whole point of this new provision is that commissioners need to be able to analyse service utilisation and effectiveness across all providers in the whole system, and that's what the data sharing agreements, which have been successfully trialled in parts of the country already, are all about delivering. There are two new requirements in Service Condition 23 on IT. The first is on the HSCN, or Health and Social Care Network, and the second is on interoperable IT systems. N3 is the system which runs the NHS Referral Service, for instance, and most providers operating under the contract at the moment will already have an N3 connection. But N3 is getting old and it is being replaced by a new approach to be known as the Health and Social Care Network. This will be a different arrangement. Whereas N3 is a single supplier system, HSCN will allow providers of clinical services to select from a range of different network suppliers, all operating to the same core specification. The process of transition over the next 2 years or so from N3 to HSCN needs to be managed carefully, and for that reason we've included a broad requirement on providers to collaborate with NHS Digital on the procurement and implementation process. The second requirement is on interoperable IT systems. The contract already includes requirements which relate to ensuring that the new clinical IT systems are procured with open interfaces, so that they're able to exchange data with other systems in other providers, subject to the right IG safeguards, of course. Interoperability of systems will be crucial for the sharing of clinical data in the future. So in the 1719 contract, we firmed this current requirement. It's now a requirement for each provider to ensure that all of its major clinical information technology systems enable key clinical data fields to be accessible as structured information through open interfaces to all other providers of services to service users. 3 things are worth pointing out about this new requirement. Firstly, further detailed technical guidance will be published, describing the clinical data which needs to be shared and the format to be used. Secondly, this requirement only kicks in from January 2019, so there's a lot of time to prepare for this implementation. And thirdly, colleagues who lead on IT assure us that this is not about providers buying whole new IT systems. It should be possible at relatively low cost to bolt on interoperability capability onto existing systems in most cases. Finally, it's worth pointing out 2 new changes which are more about how the contract operates than about new service policy issues. The first of these is about CQUIN, the National Quality Incentive Payment Scheme. In the past, there's been a specific schedule for CQUIN variations to be recorded in the contract. That is, for situations where the Commissioner and provider had agreed not to apply particular national CQUIN indicators, but to use the CQUIN payment to incentivise something different. The National Guidance on CQUIN for 1719 has now been published. You can find it via the contract webpage, and it now no longer allows for this sort of flexibility. So the wording on CQUIN variation, which used to be in Service Condition 38, has been removed from the contract, as has Schedule 4G, where variations were recorded. The CQUIN guidance does make clear that for very low value contracts, where agreeing a specific CQUIN scheme would be more trouble than it's worth, the Commissioner can instead simply agree to make the CQUIN payment in full to the provider. We used to suggest that, where this is agreed, that it was recorded within the old CQUIN variation schedule. That has now been deleted, and we suggest that the main CQUIN schedule is used instead. That's Schedule 4D. The second point, and the last one in this section, is about interest on late payments. Obviously, prompt payment in line with the timescales set out in Service Condition 36 is a requirement of the contract. The contract has always contained provisions under which interest is payable on late payments, and this has in the past been set at 2% on top of the basic LIBOR rate. It's been pointed out that this is out of line with current guidance from the Department of Business, Innovation and Skills, so we've updated the wording. But late payers be warned, this now means that the interest rate applied to base rate plus 8% applies to late payments. So now I'll hand back over to Alistair, who's going to talk about service development and improvement plans.
Thanks, Michelle. So, as Michelle said, I'm just going to say a word or two about service development and improvement plans. So, SDIPs, as we call them, can express actions that are agreed between the Commissioner and provider that either party is going to take aimed at improving any aspect of the services. And they can be agreed and included in the contract locally at any stage, at the beginning or during the contract. And once they're in the contract, they are binding. So only sign up to an action in an SDIP if you expect and are prepared to be held to account for it. But SDIPs are a local tool in that way, but they're also a national one. So as we've said once or twice along the way already, our guidance does sometimes require certain things to be set out in local SDIPs on particular topics or particular services. So for 2017 to 19, that national focus is shifting to two particular areas. And these are the two where we're expecting commissioners to agree SDIPs in their contracts with their major local providers. The first of these is that territory I was talking about earlier in this section of the presentation about the secondary primary care interface. So we're saying that a local SDIP should set out actions that the parties can take locally to make organisation at that interface more efficient for patients, for GPs and for hospital staff. So that's about local actions, but it's also about specifically making sure there is full implementation of the requirements that we've nationally put into the contract and that they're fully delivered. So that's one element of SDIP. And the other one, which is quite different, is around moving towards smoke-free premises. And this applies specifically to providers of acute, maternity and mental health services. So if those providers aren't smoke-free already, they need to be setting out in an SDIP what action they're going to take so that by December 2018, their premises, grounds, vehicles are all entirely smoke-free, as required in NICE Guideline PH 48. So that's the end of the second section of our three-part presentation. Thank you very much for listening to it. Please do now have a listen to the final third section where we talk about various aspects of how to use and manage the contract in practice.